I am excited to be here, excited to talk about anorectal malformations. I want this to be informal, so please stop me at any point for questions. And yeah, let's get going. So we're going to talk about anorectal malformations, the types, the surgeries, and what happens next for these patients. I have no financial disclosures. Before I get started, a little public service announcement. So as most of you know, the pediatric surgery group at Maryland, is your staff surgeons here for pediatrics at St. Agnes. I haven't had this happen at St. Agnes, but I think just with turnover and other things at some of the other hospitals we cover, every couple months I get on a call of somebody trying to transfer an otherwise healthy appendicitis to us, and I have to remind them that, no, we cover your hospital. We physically show up. We are available for consults, and we will come to your hospital, see the patient, and operate on them there rather than bringing them downtown, which, for a lot of people is unnecessary and just, burdens the downtown campus, but also it's better for patients if they don't have to, get shipped downtown. So all that is to say, myself and the other surgeons in the Maryland group are available, by phone. I put the office phone on there. You will get a human during the day who can direct you to one of us, either get you on the phone with us immediately or we'll call you back. And then I put my cell phone there. Whether it's in the hospital, you're dealing with something as an outpatient, we are happy to, take a phone call and try to help you figure out what's going on with the patient. And like I said, at St. Agnes, we are happy to come see a patient, evaluate. If they need transfer downtown, happy to make that happen. Or if we can take care of it here, then that's even better for everybody involved. All right, moving on now to anorectal malformations. My goals today are to help you, or I'm hoping by the end of this, you'll be able to identify the different types of anorectal malformations, name the main goals of surgical repair for these diseases, and then understand the long-term prognosis and treatment for these patients. And, some people might be thinking, well, I don't see these patients. This is a NICU problem or early in life. I will say, first off, although most of these kids get diagnosed in the NICU, there are definitely, I had probably a year ago a kid that, made it to 2 months of age and got diagnosed in the ER because they just came in with what they thought was really bad constipation, and it turned out that, this constipation was never getting better because they just did not have an anus that was in the right spot or ever going to be big enough to handle the amount of stool that was being put out. And then the other thing to know is that, as we'll get into when we talk about long-term prognosis, this is a lifelong disease. Although we, can surgically fix a lot of these kids, this is not appendicitis where once the appendix is out, the problem is over and they go on, to live happily ever after. As we will talk about when we get into long-term prognosis, a lot of these kids have chronic problems with constipation or incontinence that makes them a challenge and requires not just the surgery team, not just the GI team, but everybody involved in these kids' care to be aware of the problems, be able to support the family to make sure that these kids have a normal, functional life. All right, so we are going to talk briefly about history, a little embryology, and some epidemiology. We'll spend a long time going through the classifications, looking at pictures, looking at images, to hopefully help everybody kind of understand what the spectrum of this disease is. And then we'll talk a little more briefly about the surgeries that are available for these diseases. And then we'll spend some time on the prognosis for these kids and their long-term care. So a little history first. Anorectal malformations were described centuries ago. Lower malformations where there was an opening could be dilated and people could live, relatively normal lives. But higher malformations resulted in obstruction, perforation, death for these patients. The first surgical intervention described was by a Parisian surgeon who took a kid with a perineal fistula, operated on the family's kitchen table, and opened the perineum up, brought the rectum to the skin of the anal sphincter and sewed it in place, which is the first described anoplasty in the 1830s. But not a lot changed for these kids until, amazingly, in the 1980s when Alberto Peña described the first PSARP, which is posterior sagittal anorectalplasty. And that has really changed the game and the outcomes for these kids and is largely the same procedure that we do today. Embryology, so at 4 weeks gestation, the cloaca, which you can see at the bottom of the screen here, is a common channel for both the urogenital sinus and the hindgut. So there is a single opening for urine and stool. Is what should happen is that the urorectal septum comes in and divides that cloaca into a urogenital sinus anteriorly and the rectal canal posteriorly, and then that rectal canal finds its way to the anal sphincter. But in anorectal malformations, that separation does not occur appropriately, and we'll look at the downstream impacts that that can have. And then some epidemiology, like most rare congenital malformations, this occurs in about 1 to 4 in 5,000 live births. There's a slight male predominance, and there is a poorly understood genetic association such that if a family has one child with an anorectal malformation, you can tell them they have about a 1% chance of another child having the same or a similar anorectal malformation. There's also some associations that we know well, like the Vactral association. There's also an association with trisomy 21, and as with many congenital anomalies, IVF is a predisposing factor, maternal diabetes, and thalidomide. All right, so getting into classifications. This is a disease obviously associated with the perineal and genital anatomy, so it depends on whether the patient is a male or a female as to the exact type of malformation they might have. Both males and females can have perineal fistulas, they can have rectal atresia, and they can have an imperforate anus without a fistula. But on the male side, all of these fistulas are going to associate with the GU tract. So rectourethral fistulas, either the bulbar or membranous urethra or higher up in the prostatic urethra, or it may fistulize directly to the bladder neck with a rectovesicular fistula. And then you can also have H-type fistulas where the rectum comes down and is usually in the correct location in the anal sphincter, but there is a fistula between the rectum and the urethra. For females, obviously, the vagina and the uterus are right in between the rectum and the bladder and the rest of the GU tract, so you cannot have a urethral fistula in a female. Instead, we have rectovestibular fistulas, where it inserts just posterior to the vagina. Rarely you can have a true rectovaginal fistula, and then you can also have a cloaca, which we will describe and is associated with that embryology that we were discussing earlier. All right, so here we have the classifications broken down by how frequent they are. And the thing that I would point out is on the female side, the vast majority of these, 70%, are rectovestibular fistulas. They are almost never rectovaginal fistulas. The opening is almost never coming out of the vagina itself. It is usually just posterior to the vaginal opening, but still within the labia and the vestibule. So for females, if you see a hole in the perineum, then they have a perineal fistula. But if you don't, it is very likely a rectovestibular fistula, and that takes a little hunting to find sometimes, although you can usually identify it with a good genital exam. And then on the male side, again, if you don't see a hole in the perineum, these are very rarely do they have no fistula. It can happen, but most of the time there is a fistula, but it's to the urethra. and we just can't see it, obviously, because that is not coming out to the skin. So we're going to go through some pictures to try to describe this, which I think makes this disease make a lot more sense. So on the left side, we've got a male. We have the bladder on the screen left, and we see the urethra. We've got the pubic bone here, so just past the bladder is the prostatic urethra, and then as we get to this elbow, you get to the membranous or bulbar urethra. We've got the rectum here, and then this is a little hard to see, but the anal sphincter complex we can see right here with some of the muscle fibers running. And so we can see that the rectum is coming not out in the middle of that anal sphincter like it should be, but just anterior to it in the perineum. And then on the female side, on your screen right, again, we've got the bladder and urethra. Posterior to that, we've got the uterus and the vagina. And then again, we've got that anal sphincter complex and the rectum coming just anterior to that into the perineum. So that's our rectoperineal fistula in a boy and a girl. Now we have our rectobulbar fistula. This is going to be only in a male. We've got the rectum now, again, not coming out to the anal sphincter where it should be, but fistulizing past the prostate into the membranous urethra. If it's a little higher, it's a rectoprostatic fistula. And although, looking at these two pictures, they look very similar, the surgery becomes increasingly difficult the further up you have to go, and these patients have significantly worse long-term outcomes functionally because of that. Yes?
I know these are malformations, but especially with the last slide, these are, I think, they're good depictions of why constipation can cause urinary issues as well. Would you say that?
Yes, absolutely. So, one of the things in patients with completely normal anatomy, almost everyone who comes in and says, oh, my child has bedwetting problems. My child is really having trouble. They used to be potty trained and now, they're having some accidents. The vast majority of the time, that is not some primary urinary problem. It's constipation, and you can imagine how if this rectum was full of poop and pushing on the bladder, it becomes very difficult for children to fill that bladder up so they can hold it all night, or to control it during the day, because it just, becomes the reservoir to hold urine just becomes a lot smaller and a lot harder to control. And so the first thing that we always do when these kids get to us is make sure they're not constipated, and only after we've solved that problem, if they're still having issues, then we start going down the route of what other more primary urinary problems they might have. But the vast majority of them, once you get the constipation solved, you get everything solved.
Sorry I changed topics there. I just like this.
Yeah, no, it's a great point. And I think, we as surgeons love anatomy. It's, we love studying it. We love looking at it. But I think there are some areas of the body that are tough, because you think of the GU system and the digestive system as being relatively separate, but in the pelvis, they are, intimately associated with each other. So it's a great point. Going higher up still, we get to a bladder neck fistula. Now you can see we're connected directly into the bladder. Again, it looks like it's just a few millimeters apart, but the surgery becomes, completely different, to the point that we'll usually go through the abdomen to find these fistulas and take them down. And we can see on your screen left here a contrast study. So this patient had a colostomy created. They are then inserting a catheter here through the mucus fistula that goes, down into the sigmoid colon and then the rectum, and you can see a trickle of contrast getting right in to the base of the bladder there, and then filling the bladder and starting to fill the urethra. All right, and then you can have patients that don't have a fistula. Now again, these are rare, so even if a patient comes to us, they get that contrast study that we showed here, and we don't see it filling, we are usually somewhat skeptical that it's truly no fistula. We kind of assume that there is a fistula, and you can see why, because even if there is not an actual fistula here, oftentimes this rectal wall will be right up against the urethra, which makes the surgery challenging because the last thing we want to do during this surgery is damage the urethra and create another problem for these patients. All right, moving on to female anatomy now. This is, a repeat of what we were looking at earlier, but now instead of that fistula coming out in the perineum, it's coming out all the way in the vestibule, sharing a wall with the vagina, but coming out just posterior to the vagina. And again, during these surgeries, they are challenging because you're trying to get this rectum off of the vaginal wall without damaging the vagina. All right, and here we are going to talk about cloacas. So like we said in the embryology slide, a cloaca is just a common channel that has both your urogenital sinus and the rectal canal. And so in the same way, in females, that urogenital sinus has separated into the urethra anteriorly, the vagina in the middle, and then posteriorly the rectum. And in these cases, that cloaca never completely separated, so when you're looking at the anatomy, there is a single hole where all of this is supposed to come out of. In most cases, it's a short channel, which we define as less than 3 centimeters, but you can also have a long channel cloaca, which makes the surgery more challenging and also makes the outcomes, functional outcomes, worse going down the road. And then one thing to think about when you have a cloaca is you will often get hydrocolpos, which is where the vagina, still impacted by maternal estrogen, has a lot of secretions that are unable to drain appropriately, and then you will get this large mass in the abdomen that can cause inability to urinate, needs to be drained, and this is one of the more urgent issues that we will have with these anorectal malformations. All right, so the exam. I think this is a really nice picture of how to do a genital exam on a female in an infant. Grabbing the labia on both sides, pulling towards you and out, and you should be able to get a really nice view. We have obviously the labia on both sides, the clitoris screen on the top of the screen, and then we can see the small hole for the urethra, the normal hole for the vagina, and then in this case, we've got a fistula in the perineum. It is outside the vestibule, so this would be a perineal fistula in a female. On the left, we've got a male. Again, anterior is screen up, posterior is screen down, and right at the posterior aspect of the scrotum, you can kind of see a small hole that has a little stool coming out of it. And then screen right, again, we've opened up the labia, and here, this is fairly typical. These vestibular fistulas are really hard to see, so a lot of times the only way to really find them is to probe, and in this case, they've got a probe going into that fistula, which is a vestibular fistula. All right, the picture on the left here is opposite, so posterior is up now. So here again we see the labia, and then just posterior to that there is a small fistula, and on the right side we see a fistula that is actually in the vagina. So like we talked about, this is very rare but can happen, so that is an actual rectovaginal fistula. On the left side, this is called a fourchette fistula because it is still in this membranous looking tissue that you will often see. Over time, that's going to epithelialize and look more like regular skin, but we will get a lot of calls for what look to be fistulas because the opening is in this, sort of mucosa looking skin, but a lot of babies will have that skin that just goes all the way down the perineum, all the way to the anus. So one of the key things to look for, in this case, it really does look like a fistula. There's no evidence of an anal sphincter, but if it looks like an anal sphincter around there, then sometimes it is just a normal anus that happens to still be in this fold of less mature skin. Here is another example of somebody probing a vestibular fistula. All right, and then this one is interesting. Looks clearly like a perineal fistula right at the back of the labia, but you can also see that this looks like an anal sphincter complex. So this actually is not an anorectal malformation. It is just a very anteriorly displaced anus, which there is no surgical treatment for. If the opening comes out into the anal sphincter, there is nothing I can do surgically to make that better. So there is some discussion about the size of the perineal body and what that does to constipation issues down the road. I've never seen really good data on that. There are discussions that with a small perineal body you have more constipation, but not totally clear how reliable that relationship is. And like I said, there is nothing to do surgically. These patients just get treated expectantly, and if they need something for constipation, obviously you just deal with it like regular constipation.
Would you know that just by looking at it because it looks like a sphincter, or would you have to do some kind of contrast study for sure?
So if we were confused, this one seems pretty clear. So if you looked at it and saw this, you did a digital exam and it had good plasticity, so it opened up nicely, and you're like, okay, the opening is appropriate, then there probably wouldn't be anything more to do. In a case where you are concerned though and you're not sure, then we'll actually take these kids to the OR, put them to sleep, and then we'll use an electric probe to stimulate the muscle, and you'll be able to tell where the anal sphincter complex is. And in this case, I'm sure it was right here. But in other cases, even if you don't see the sphincter complex in that midline, as you're stimulating it, you'll see very little movement, and then when you get to the sphincter complex, you'll see it wink as those muscles contract. And I have had probably a couple cases where I had, anteriorly displaced and somewhat tight sphincters that when we stimulated them turned out to be fine. We just dilated them up, and then the kids, got to stop the dilations and just pretend that nothing ever happened. But it wasn't completely clear. It's not always completely clear. Here are a couple of kind of particular things you might see that indicate a low malformation. So if you see a bucket handle, usually you will not initially see a perineal fistula, but a lot of times if you give it a day, they will start stooling out of a fistula, or if you probe the area, you can find the fistula. And then if you see beading of the median raphe, that is just, meconium and or other mucus that is kind of pushing through, and that usually means a very low malformation that with a little time will usually open up, or you can probe it and open it up. All right, on your screen left here, we see a single opening again. They're pulling the labia out and towards them, and you can see that we only have one opening there. So this is very concerning for a cloaca, which, as you can see on the image below, is that common channel for all three, the urethra, the vagina, and the rectum. And then on the screen right here, this is a cloacal exstrophy, which I, as a med student, confused with cloaca and cloacal exstrophy, and although they are on the same spectrum, this is a very different disease, obviously. You've got an omphalocele, you've got the two hemibladders that are opened up, you've got a prolapsing small bowel, We are not going to talk about this anymore, but I did just want to bring up the term because I think it does get confused with cloaca, but cloacal exstrophy is very different. All right. Any questions about the classifications? Clear as mud to everyone? Perfect. All right. Going through some of the surgeries that we do, the most important surgery that we offer to these patients is a colostomy for patients that can't get a primary repair because, this is largely a lifestyle disease, but the big thing that you cannot miss is getting them diverted so they do not have obstruction, perforation, death. So colostomy is critical for a lot of these patients, although it can usually be reversed. It is the most important thing that we do. The PSARP, again, the posterior sagittal anorectoplasty, has offered these patients an opportunity to have regular bowel movements, to have normal continence, although as we'll see with the outcomes, that is not a guarantee. It is the best that we have to offer and has really revolutionized care for these patients. And then with low malformations, we can often do this just through the perineum, but with higher malformations like a bladder neck fistula, they will often need a laparotomy or a laparoscopy to go in and divide that fistula in the abdomen and then bring the rectum down. In the case of cloacas, you may need to do a urogenital sinus mobilization where you essentially get rid of that cloaca and bring everything down to the perineum to give them a more normal anatomy. And then in the case of a long channel cloaca, you may have to do a perineal reconstruction, bringing different pieces of anatomy in to recreate the appropriate anatomy. So again, looking at our classifications and the incidence of these classifications, the ones I've highlighted in yellow here, where you either don't have a fistula or have a fistula to the urethra or a cloaca, all of these cases need a colostomy. The reasons for that is one, like we talked about, we can divert them so that they don't have obstruction, and then two, that'll give us access to the rectum from above so we can shoot a contrast study and figure out their exact anatomy. For a lot of these patients, we don't see anything, particularly for boys, we don't see anything on the outside, and the only way for us to know what we're trying to find when we do surgery is to do a colostogram where we shoot some contrast in and see where that fistula is located. So, and then for girls with a cloaca, because of the complexity of that reconstruction, we will always bring up a colostomy, let them grow, and then deal with the reconstruction down the road. Because not only do you need to figure out whether it's a long or a short channel, you also need to do a ureteroscopy, because some of these kids will have a bifid uterus, and you'll want to deal with some of those problems at the same time as your surgery. So the goals of surgery, like we said, prevent bowel obstruction, perforation, death, that is the big one. The rest of these are mostly lifestyle, trying to get them to be able to stool normally. So we want to improve and give them the best chance for fecal continence. We want to avoid stenosis and constipation issues. We want to get rid of that fistula to the urinary tract so we can prevent UTIs. And then in the case of cloacas, particularly those that are long channel or have issues with vaginal drainage, we want to create a pathway so the uterus and the vagina can drain. So the first thing that we do in a lot of these patients is a colostomy. Traditionally, we have been taught to do a divided colostomy because there was concern that poop would jump from the ostomy to the mucus fistula and then continue to accumulate. The data for that is, not great, but the big point is you want to leave both a colostomy and some access with a mucus fistula so that any mucus can drain out, but also so that you have access to it so that you can shoot a colostogram. This is the posterior sagittal incision. You can see here, they've divided the perineum, they've identified the rectum, they put some stitches in it to give it some traction. This is a cartoon of that. Again, you've got the perineum opened, you've got the rectum here, the light tan color, and then you never see this musculature like this, but it's nice in the cartoon to know this is the anal sphincter, this is where you're gonna bring this rectum eventually. And because, as you can see in this previous image, there's no way to see those muscles there. We use that electrostimulator to identify exactly where those muscles are so we can mark them and put the rectum in the right spot. So this is, again, another cartoon of they've identified the rectum, they've now opened it, and they've identified their rectourethral fistula. And then they're going to divide that fistula off and oversew that, and then they're going to mobilize this rectum off so they can bring it up. Again, here they've drawn in the sphincter complex so you can see exactly where it is. So in patients that have typically a long channel cloaca, they may not have adequate vaginal length to reach the perineum to allow the uterus to drain. This is not something that needs to happen early on because, before puberty, the uterus is not producing a lot of secretions, but at some point you need a pathway for the uterus to drain. In this image, they are using the sigmoid colon. So they're going to divide at the two lines here. They're going to reconnect the colon to the rectum, and then they're going to use this as a conduit, as a neovagina that they are going to stitch both to the small vaginal length that they have innately, and then down to the peritoneum to allow drainage and for sexual purposes. It is in theory not impossible to get pregnant this way, but it is extremely rare. And these patients absolutely cannot deliver vaginally. People have tried, it does not work. Yes?
I'm one of the medical students.
Mm-hmm.
I was wondering, so when I go to surgery, I went to a office.
Mm-hmm.
They were saying how neonatal bladders are just not as long lasting as just having a colostomy. So I was curious in the case of a neovagina, what are the outcomes for that?
So it is rare enough that we don't have great outcomes on it. Certainly, sexual satisfaction for these patients is dramatically worse than the regular population. That said, the vast majority of the time, patients can have normal, penetrating sexual intercourse. And although, like I said, their sexual satisfaction may not be what they want, they almost always are able to perform the act, which for a lot of people is a big improvement over not being able to at all. And then I think the thing for a lot of these patients to realize is vaginal intercourse is not the only way to enjoy a sexual experience. There are a lot of other ways to do it, and they just have to be kind of coached that although they have this option, they also have other ways to connect with their partner that are not necessarily vaginal intercourse. And then if they want to get pregnant, they can still do that through in vitro fertilization methods or other methods, and they can still, if they have a normal uterus, they can carry a pregnancy to term, and they just need a C-section to get the baby out. Any other questions about that? Great question. Okay, so, this is incredibly rare that we need to do this, but it is, an important thing to be thinking about, particularly if you have a patient with a cloaca. Okay, Getting into how these patients do long term. So this table, it helps us predict how these patients are going to do. There are 3 things that we care about: the type of anorectal malformation that they have, any spine abnormalities that they have, and we evaluate the sacrum. So you can see the list of anorectal malformations here. The more points you get, the less likely you are to have good bowel function. So our lower malformations are on top, including rectobulbar fistulas, anorectal malformations without fistula, rectoprostatic or short channel cloacas fall into the intermediate category, and then bladder neck fistulas, long channel cloacas fall into the more severe category. In the same way, we look at spinal abnormalities, myelomeningeal being the worst situation, and you can see the other things that we look for. And then finally, we'll talk a little bit about the sacral ratio, but we measure that to give us an idea, again, of just the prognosis and any other major sacral abnormalities like a hemisacrum puts you at increased risk. So looking back at our classifications, the ones highlighted in green here are low malformations. These only get 1 point. They have the best outcomes. The ones highlighted in yellow are your intermediate outcomes, and then the ones highlighted in red are your worst outcomes. The sacral ratio is not super important for you guys to think about, but just to know what we're thinking about. We measure from the iliac crest to the sacroiliac joint, and then we measure from the sacroiliac joint down to the end of the coccyx. We divide this lower one by the upper one, and the lower that ratio is, the worse they do. If they have a ratio greater than 0.7, that's normal. Between 0.4 and 0.7 is intermediate, and then less than 0.4 is the worst outcomes. All right, so getting into the long-term prognosis for these patients. So we are going to talk about voluntary stooling, the ability to sit on a toilet and make yourself go. We're going to talk about soiling, which is defined as having a fecal accident more than once a week, or at least once a week. Fecal continence is essentially the opposite of soiling. And then constipation and urinary continence are, I think, a little more self-explanatory. So when we look at these patients, our best outcomes occur in the lowest malformations: rectoperineal fistulas, rectovestibular fistulas. You can see, more than 90% of these patients are having voluntary bowel movements. They have some control. But 20 to 40% of these patients are having fecal accidents at least once a week. So, that is a huge number of patients. And these are our best outcomes. So, it is really important to set expectations early on that even though we can fix this problem, we can make their anatomy relatively normal, there is still a very high chance that they are going to have some problems controlling their bowel movements down the road. And then, tons of these kids have constipation issues, which is, a really painful double whammy when you have both constipation and fecal incontinence. But almost all of these kids have normal urinary continence. As we work our way down, rectourethral fistulas do a little bit worse, with almost 50% having soiling issues, and then short channel cloacas do even worse than that, with more than half having soiling issues. And then when you get to the lower malformations, in these cases, a lot of patients don't even have voluntary bowel movements. They really have no control back there, and their rate of soiling is extremely high, more than 75 to, in some cases, 90%. These kids also tend to have more urinary continence problems, and that tends to be more of an issue in females, just for the anatomy reasons that you can imagine. There's a shorter urethra, it's harder to control that urine. So the important thing to tell these patients and to make sure they know is, even though we have these not great functional outcomes from a sort of normal voluntary bowel movements, normal fecal continence standpoint, we can get 85 to 95% of these patients to be functionally continent, meaning they can go to school, they can not be in a diaper, they can go all day without having an accident. But it does take some effort through bowel management programs and other kind of tricks of the trade that we use to keep these patients continent during the day. So in some cases, it's just time stooling, making sure they go in the morning before school so they're relatively empty and can control it all day. In other cases, we have to use laxatives to try to clean them out. You know, maybe they'll take some Miralax at night. By the time they wake up in the morning, they have a big bowel movement, and then they can go through their day without a problem. In other cases, we're doing the opposite. You know, they have decent control if we can make them a little bit constipated, so we're using stool thickening agents or anti-motility agents, trying to actually get them a little bit constipated so that they have better control. And then in other cases, these kids, you know, they get up in the morning, they give themselves an enema, that cleans them out, and they can go the rest of the day without needing to have a bowel movement, without having an accident. The Pyristine irrigation system is kind of like the next level enema, which we'll talk about a little bit. And then in the cases that we really struggle, then we talk about surgical procedures like a cecostomy or a Malone antegrade continence enema procedure to allow them to do antegrade enemas that can clean them out. So we have really stopped doing the antegrade enema procedures because of the Pyristine irrigation system. You can imagine with an enema, you know, you are sticking basically a ketchup bottle up the bottom, you're squeezing a bunch of fluid in, trying to get them cleaned out. But if you've ever had to do an enema on a kid, you know that half of it comes out on you as you're pushing it up. So what the Pyristine irrigation system does, it's basically a Foley catheter, although it's got a really big balloon, so that you can blow that balloon up and then you can get high volume, high pressure fluid in there to really irrigate the system out and get them cleaned out. Yeah.
Any side effects or risks with that you worry about?
So, you know, a lot of patients come in, or a lot of parents come in, and they're like, I don't want my kid to be dependent on these. If I start Miralax, I know I'll never get them off Miralax. So, I mean, it's a little bit of a catch-22, because if they need Miralax, in some ways they're already dependent. But we don't have any evidence that by starting Miralax, you are going to keep them from being able to get off it later in life. It's not a situation where if I could just, you know, get the diet right and avoid Miralax, then they wouldn't need Miralax later. So I think one of the things to reinforce to patients is the real problem that can occur if you have chronic constipation is that you blow out your rectum and sigmoid colon such that it will no longer squeeze. That is going to put you at risk for needing either procedures or, you know, chronic constipation management down the road. But even if you need Miralax for 2 years, keeping that colon normal is going to give that kid a better chance to be normal later when maybe they have a little more control of that area than letting them be constipated, letting them, you know, dilate that colon to the point that it's no longer functional. So the nice thing about almost all of these agents is they don't have a lot of side effects other than, you know, overdosing on Miralax is giving the kid diarrhea, and then you just have to kind of back it off.
I meant particular of this.
For the Pyristine?
Yeah.
No, I mean, the nice thing, similar to Miralax, whatever agent you're putting up there, whether it's glycerin or Castile soap, it's going to stay, you know, it's not being absorbed systemically, so you can really, you know, do whatever you need to and not have to worry about long-term impacts. The The only issue that we do run into sometimes is, as the kid gets older, they just kind of get traumatized of things being stuck up their butt, and it becomes impossible to keep doing it.
Should we have this in the ER?
I love the peristeam irrigation system. I would think about it. I think it, is a potential way to clean some kids out to avoid having to, stick an NG tube in and go lightly in for a day in the hospital.
Where do you give them Versed or anything? Where do you do this, in the office?
Normally, we're teaching these kids to use this at home. This is not like typically an emergent, like, oh, we're going to use this to get them cleaned out right now. It's, we've tried enemas. Mom's like, hey, I'm doing these enemas, but half of it comes out on me. We're not really getting him clean. He's still having accidents at school. And then we will show them how to use the peristeam system in the office, and then they'll work on it at home and do it at home.
And the advantage is that the balloon prevents it from coming out immediately.
Exactly.
And the pressure is higher.
Yeah, so you can get more pressure and more fluid. It can get higher up. You can get them just a better clean out.
And what do you tell them to put in there? Anything? Like, what you say, Castile?
Whatever, yeah, you can, some people will do fleets. Some people will just do saline. And then some people, and again, this is all kind of guess and test bowel management stuff, but some people will do a combination of Castile soap, glycerin, and saline. And then for kids who, either I have not had a kid who could tolerate the peristeam system that needed anything else done. But every once in a while, you'll get a kid who just, they've been traumatized enough, or they've gotten older and they just won't tolerate it anymore. In which case, we will talk about a cecostomy or a MACE procedure. In this image, you're seeing the MACE, where we create a valve with the cecum over the appendix, and then we sew the appendix up to the base of the belly button so that they can catheterize themselves and give themselves antegrade enemas. And again, once you get this set up, it's just a kind of a guess and test system of exactly what you use and how often you use it. I will say I have not had to do this in an anorectal malformation kid, but I have had a couple of functional constipation kids that it has changed their life. Like, we're missing school, we're having accidents almost daily, had to wear a diaper, and within a couple weeks, they were pain-free, getting washed out, not having any more accidents, and parents are like crying. They are so happy when this works. All right, so wrapping up here. Hopefully, I have kind of impressed on you how understanding the type of anorectal malformation that kids have determines what treatments we offer to them, what their course is, and then what their long-term prognosis is. The main goal of surgery is to prevent bowel obstruction, and then the rest, like we talked about, is really kind of more lifestyle, trying to get them to be able to live as normal lives as possible. But we just have to remember that a lot of these patients struggle with lifelong bowel issues, so we got to set realistic expectations up front. A lot of these patients, I tell them up front, they are going to see me, for life, or at least until the kid graduates from college. Unfortunately, you get these repaired early, the kid is pooping, they're in a diaper still, the family thinks it's done, and they don't realize that you're not going to see some of these problems until you're trying to do potty training 3 or 4 years down the road. I will just acknowledge my partners, who I always appreciate helping me think through these patients, and then a couple of my mentors at Cincinnati Children's, where I trained, who are kind of the colorectal gurus of my life. There are some references if anybody wants them, and then I'm happy to take any questions.